All right, we're going to start with managing behaviors in the facility. Now, again, this is more of a reminder. I know that a lot of you have already extensive training in this type of setting, right? And it's just sometimes it's nice to just hear it again and maybe pick up a few pointers. So we're going to get started right away. If I'm going too fast, please just stop me, let me know. The first thing that we're going to address is managing behaviors, challenging behaviors in the facility. Now, while there's challenging behaviors just about any facility, I'm going to say sometimes the culture, sometimes it's really specific to this particular setting. So I really want to hear just shoot out the answer. What type of behaviors are you seeing in this particular setting?
Is that regarding staff or that's regarding patients?
Patients. I'm sure there's behaviors with staff as well, but just mostly with, we'll focus with patients. Okay. We'll start there.
Okay, so I'll start. Some of the behaviors. It's throwing urine, and actually at you, hitting, spitting, cursing you out, whole 9 yards.
Okay, yeah. Sound familiar?
Yep. Verbal abuse.
Verbal abuse, sure.
Lying.
Verbal threats, lying, agitation, falsifying different stories, right? Fabricating different things, perhaps. Yeah. So all of these behaviors, again, they are very common, but sometimes they are very specific to this location as well. All right, so the workshop today, I'm gonna break it in two. First is the challenging behaviors that we're gonna be addressing, and second would be suicide, how to identify suicide behavior. All right. So some of the factors that contribute to these behaviors would be cognitive decline, right, and confusion. We have a lot of our patients that their memory perhaps is not as it used to be. They have some type of diagnoses. Mood and psychiatric symptoms, depression, anxiety, hallucinations maybe, right, some delusions. Adjustment difficulties, meaning they just got transferred from home, perhaps a hospital. It's a new setting for them, right? And it's taking a little while for them to adjust. Internal medical factors such as pain, right? Lack of sleep, hunger, thirst, and of course, environmental stressors, right? Lights too bright, it's too noisy. My roommate, TV's too loud, I can't sleep. So those are some of the reasons that we see, right, with behaviors. Now let's break it down to mood, because I feel like that's probably one of the biggest contributors to these behaviors. Depression and anxiety, those are big contributors to these behaviors. And again, they come from a place where we call it ideology of challenging behaviors. So that means that physical, environmental, and psychosocial needs have not been met. Now, this is important to understand because it's not only in this facility or with patients. I'll give you an example. If one of our needs was not met, the ones that I just mentioned, physical, environmental, or psychosocials were not met, we would probably have some behaviors, right? So it's not just unique to our population. It's a universal thought. It's a universal theory. So what are these physical unmet needs paradigm? Physical factors, again, temperature, hunger, thirst. We know that quite well, right? If we are thirsty, hungry, we get what? Angry, irritable, upset. We start probably lashing out, maybe, right? Environmental factors, again, light, noise. Make sense? Environmental factors, right? At home, when we're trying to sleep and somebody's blasting the music next door, what happens? Yeah, we probably don't like that, right? So again, that's our environmental factor. And the last one is psychosocial. Loneliness, isolation, boredom, right? If we're lonely, what happens? We tend to get what? Probably depressed, right? Yeah, maybe a little sad, sure. So again, those are the unmet needs paradigm. And the reason why it's important to understand is because we have to understand where those behaviors are coming from. Some of the residents are not acting out just to act out, right? There's a reason behind it. I'm gonna say 99% of the time. Any questions before I move forward? One way to understand and really, really capture this is the ABC model. Really easy to remember. The antecedent, right? The behavior and the consequence. Again, if you're looking at a behavior, the antecedent is what happened before the behavior occurred. Right? What happened before? Well, the resident perhaps got a pretty bad call, or maybe they're hungry, right? So that's the antecedent, that's the A. B is the behavior. We describe the behavior, and this comes in handy when we're documenting. What does the behavior look like, right? It's sometimes not enough to say, well, they were not happy. Well, how do you know they were not happy, right? So the behavior, meaning describe the behavior. And finally, the consequence, or more so it's about what happened after the behavior. Did it get reinforced? Did the patient get a lot of attention as a result of the behavior? What happened? Or the consequence was, we did something and the behavior changed or it stopped. So that's why it's important to understand the ABC of behaviors. Does that make sense?
It does.
Okay, yeah. And it's a very easy acronym to just remember it, ABC. What happened before, the behavior, and then the consequence. All right, moving along. So what are these strategies to handle these situations, these behaviors? I'll tell you what, you're probably already doing all of these strategies. You're probably already completing them, right? Listening would be one. What works for you guys? What happens? What do you do that actually works or has worked in the past?
Taking them to
Activities, right? Engagement, right? Sure. Engagement, using gentle touch, using eye contact, not startling the patient.
That's devastating. It's devastating.
Correct.
Changing your tone of voice.
Changing the tone of voice. What happens, and this is human behavior, right? This is all of us. What happens if we encounter someone and they approach you and they're shouting at you? Yeah,
It makes you feel the type of way.
sure. I'm not easy. All of a sudden my guard's up, right? I'm probably gonna mimic that behavior, right? Good, thank you. I'm probably gonna mimic that tone, right? If their tone's loud and mine is loud too, guess what? Nothing's gonna get accomplished, right? If you do the contrary, for example, somebody's shouting, I need this, I need that, and you come in and say, what is it that you need? Well, they're gonna have to lower their voice so that they can hear you. Introduce yourself. I know that the patients know you, right? Good morning, Dr. Caldera here, coming in. This is their space,
Absolutely.
right? This is their home temporarily. What happens if somebody walks into your room at home?
Excuse me.
Excuse me, yes, absolutely. So let's give them that space, right? Let's allow them to feel, right? To feel that they're in a place that they can trust. All right. Another thing that I'm going to suggest, and again, you're probably already doing this. A lot of patients, you get to know them, right? And you interact with them day to day. And sometimes these patients talk to you. And they'll say stuff like, oh, I'm feeling a little down, or I'm a little upset, I'm feeling sad or anxious. And as good humans that we are, what do? Oh, no, come on. Be happy. We all love you. We all care for you. You have a great family. So what are we doing to that communication? We're minimizing, right? We're not allowing them to express their feelings. We're saying, no, no, no. You're not allowed to feel that way. You better be happy. And that comes from childhood, right? For those of you that have kids or nieces or nephews, right, or have dealt with kids, if they fall, what do? Oh, don't cry, it wasn't that bad, right? So we teach the child that they're not allowed to express emotion. As a result, when those emotions build up, what happens?
They like running around like Godzilla with the bus.
Yes,
Yeah.
off the walls, right?
Off the wall.
Well, in this case, what happens is a patient's not going to say, I'm really sick of you telling me all this stuff. I'm feeling very invalidated. No, they're probably not going to say that. But what's going to happen is it's probably going to come out big, right, and loud. And we're probably not going to like it. So again, validate people's feelings, patients' feelings. It's okay. Your job is not to solve any problems, right? Our job is to listen. Oftentimes, again, as good humans, right? No, do this and you're going to be fine. Are they? But we're trying, right? We're just trying to make them feel better. Yes?
Sometimes they'll shut down and feel like they can't trust you to talk to you.
Great point. Absolutely. Why am I going to talk to you? Every time you talk to me, you don't validate me, or you shut me down, or you block my emotions, right? Very good point. Questions. What happens if you did all of that? Because I know you have great ways to deal with these behaviors already. No matter what you do, oftentimes these behaviors are going to occur. And unfortunately, we can't prevent every single behavior. We wish, right? But it's not possible. If the patient engages in some type of behavior, we immediately jump into de-escalation. We have to guard for our own emotions, right? The patients are not here to get at us, right? It's not our fault. If I say don't take it personally, well, you might, and that's okay, right? But just make sure that you understand that this is not a personal matter, right? These patients are going to lash out at whoever is in front of them. De-escalation. Maintain your composure. Be aware of your own emotions, your tone of voice, and body language, right? What does it look like to you guys?
Ooh, baby. Yeah, ma'am. Right there. Stay.
Right?
Yep. Stay.
Your stance, right? Maintain eye contact. Keep arms at your side. If you start doing this, what happens?
Throw your hands in there.
What happens? You become bigger, right? In a threat. That would be in a probably different setting. Yes, I agree. But in this setting, you become a threat to them, right? Sometimes they're lower than you. And by default, they already feel inferior. Right? So make sure you keep track of your stance. No physical contact at this point. If a patient's already escalated and they feel upset and angry, a simple touch might throw them just off. Might be a threat. Your approach, always approach the resident from the front and not the back. Why is that? Sure. Vision, peripheral, and sight and hearing. Probably not very good, right?
That's right.
So you'll startle them if you all of a sudden appear. So make sure that they see you. Give them a warning. Always approach the resident from the front, respond calmly, and provide support with positive and friendly facial expressions. Now that's tough, right? Because we all wear masks. So it can be a tough one. All right. Effective verbal responding. Using a relaxed tone. Remember, they're going to mock your tone. Remember, whatever the resident's replying to you, you're probably going to mimic that. Careful, right? Just keep track of that. Redirection. Provide options for other activities or places if appropriate. Do not make assumptions. Listen to the resident and determine what they are concerned about rather than assuming the situation. oftentimes we assume, right? Oh, they must be hungry. No, they're not hungry, they just ate. This is the reason why. Listen. And finally, teamwork, right? Staff communication is an essential tool in addressing combative behavior. Staff should share information on patients. You know patients more than anyone else here. Let us know what works for this patient, what doesn't work. Communicate. And remember the ABCs, right? Antecedent, behavior, and consequence. All right. Very quickly, I'm going to move on to 5150 holds. And I know you probably have had a lot of training in this. I want to make sure that this is incorporated. We've had a lot of increases in suicidal ideation attempts in the last I'm going to say the last year. So it's important that we understand what it is. Anybody want to give it a shot? I know you all know. Just want to get out of here, right? All right. 5150 is a number of the section of the welfare of the institutional code. Is that important? No, but it's there. Which allows an adult who is experiencing a mental health crisis to be involuntarily detained. And that's the key word, involuntarily. It becomes a scene oftentimes because patients do not want to go, right? And so if somebody's being involuntarily, what's going to happen?
They could become combative or volatile.
The situation just escalates. But this is important. Once the patient is admitted to the hospital, a clinical team then begins their intake process. And the reason why it's important is because when the patient is released, they're going to give them the best opportunity possible. When they take them, when the officer comes in and takes the patient, they do a very thorough evaluation, a psych evaluation, and they do a lot of recommendations for this patient. It's a good thing for the patient. Even though they don't want to go, it's definitely a good thing. So keep that in mind. Okay, the last thing that I want to address in this section is the post-event. What's a post-event? After a crisis. Report and document. Again, teamwork. It's so important. It can prevent other situations. Evaluate the response that you had with the patient and see if, hey, did it work out? Should we do something differently next time? We communicate. You're doing it. You're implementing education and training based on findings, right? And then we address and identify needs by reviewing and sharing successful staff interventions. All right. Questions on challenging behaviors? Pretty straightforward? Yeah, look, guys, you guys are great. All right. The next topic is a little bit heavy. I will say there are a lot of resources. Please take advantage of the resources if for some reason this presentation is eliciting some type of behavior or some type of feeling. We're going to be discussing suicide ideations and attempts. First, let's start with the definition, suicide. There are 3 suicide definitions. Suicide, number 1, is when a person takes their life. Pretty straightforward, right? The next definition would be a suicide attempt. Again, pretty straightforward. An effort by someone to take his or her own life, which is not completed. They're not successful. Sometimes you hear, oh, it was a cry for help. Maybe. Maybe it was. Maybe it wasn't. But the reason why even those cry for helps are important is because especially in our population, most likely they will succeed. And finally, passive or indirect suicide is when an older adult tries to cause his or her own death by refusing medication or food. At this point, of course, it is essential to get help for the resident who is refusing to eat or drink or take any type of medication. Questions? According to recent stats, suicide rates have intended to increase with age and the rates of suicide for those over 65 and up. Any reason? Can you speculate as to why? Why is it so much higher with adults 65 and older? Yes. Sure? You're probably all right. I know you're probably thinking it, right? And it's probably right. Every year, more than 5,000 Americans over the age of 65 die by suicide. This is about 14 suicides every day, or 1 suicide every 100 minutes. And these stats come from the Disease Control and Prevention. Pretty shocking, right? Why do patients 65 and older succeed? According to the research, they are deliberate. They've been thinking about it, right? They probably lost family members, right? They're feeling hopeless. But most likely, they've been thinking about it and they have a ways to do it. Versus some young kid probably that just randomly thought about it, right? And most likely will not succeed. But they can still hurt themselves. The most common means of suicide in our setting and attempt suicide in senior living is by hanging, cutting, and overdosing in medication. As you guys leave today, there's some worksheets here, and it's actually a kind of a cheat sheet to assess minimal, lower, and higher risk. Because our risk is not the same. We have immediate versus not immediate. It's still risk, though, nonetheless, right? And we still have to address it. All right. Let's look at these immediate risks. There's 3. Threats. Threatening to hurt himself or herself, right? Pretty much just saying it. Yeah, I'm going to hurt myself. That's a threat. Can't get any more clear than that. That's a threat. Looking for ways. All of a sudden, they're researching, calling people, looking at guns, researching guns, buildings, active research. And the third one is talking or writing about death. Now, this one's a little funny because think about this. Just because somebody talks about death, it doesn't mean that they want to die. As we get older, thoughts about death or even talking about death can be a way of coping. It's not about what they say, it's how they say it. Does that make sense? Is that clear?
Yes.
Yeah. Okay. So that's the immediate threat. What do we do when there's an immediate threat?
Yeah, to call 911.
We take immediate action, correct?
Immediate action.
Absolutely. We take immediate action if you notice any of the warning signs, the 3 warning signs that I just described. Someone threatening, looking for ways, and talking or writing about death. That's kind of out of the ordinary. Those are the immediate. Make sense? Now, there are other warning signs, but they're a little less immediate. And these are hopelessness. Just because you're feeling hopeless, it doesn't mean that you're going to go hurt yourself. Rage, uncontrolled anger, acting reckless, withdrawn, dramatic changes in mood. Again, these are risk factors, but they're not immediate. Does that make sense? Can you distinguish the difference? Right? There's a feeling. It's not more of an action or saying you're going to do it. These are a little bit less immediate. What do we do if there's less immediate signs? What do we do with that?
Watch and report.
Good. We just don't leave it alone and say, well, hopefully they get better, right? We also keep track of it. We also take some type of action. It may not be the immediate response, right, or 5150, but we take some type of action. The first thing that we're going to do, if somebody reports that, is we won't leave the resident alone. What does that mean?
One-on-one.
If there's an immediate threat, right? We don't want to leave the resident alone. Take suicidal thoughts seriously, immediately provide a one-on-one supervision. Number 2, we notify the charge nurse who should complete a suicide risk assessment. We notify on-call social workers with results of suicide risk assessment. Now, if they come in and they say, well, you know, the risk assessment, it was pretty low. Okay, well then that becomes a little bit less of a threat, right? But if the risk assessment is high, then that's when we take immediate action. In this brochure that I have here, again, what determines minimal risk, lower risk, and high risk? And what do you do with that? So make sure you take one of these. They're good reminders to just have and review once in a while. Questions so far? Everyone's doing okay? Everyone's hot? Yeah? Okay. All right. What to do in the event of a suicide, death, or attempt? Now this is more serious, right? It's happening. It happened. We immediately call 911, somebody mentioned earlier, right? We don't leave the resident alone, we already know that. We send another staff member to the front door to guide the EMTs so we don't waste time. And we make sure that the staff with medical training know how to begin medical care for this type of situation if needed. Does this sound pretty familiar? Pretty straightforward. Immediately after a suicide, not attempt, but death, it has happened. It's happening in our communities. It's happening outside of our communities. And if you think it can't happen here, let's think again, right? It's possible anywhere. Immediately after we call 911, as soon as it's obvious that the medical attention may be necessary, again, we designate the staff who will notify the resident's family. The designated staff members will assist staff and be present for the family and any law enforcement persons who may also be present. The designated administrator will notify the state regulatory authorities as required by state regulation. And finally, the designated staff member or members will provide immediate support to survivors. Who are the survivors? Who said us? Yes, all of us. You're a survivor. You interacted with the patient or not, but the patient lived here. It's a place of work. You are the survivors. Questions?
If let's just say the patient has a roommate and it's going on, should we remove that roommate from that room? Because then it's gonna mess them up too.
Sure. Good question. Should we remove the roommate from the immediate, from the room when it occurred, right? I'm assuming they succeeded. You know, that's a good question. It really depends on the situation, right? If the roommate is experiencing some type of feelings about the event, absolutely. Otherwise, we tend to make sure that everyone's just comfortable, because sometimes the roommate might not be right. So it really depends. Or the roommate may not know the situation, and if we start making some type of assumptions that they know, it may be a little confusing. Okay, so it really depends on the situation. Good question. Patient is a 68-year-old Caucasian male admitted to this facility 2 weeks ago. Patient has a psychiatric diagnosis of a depressive recurrent with anxiety unspecified. Patient does not have a history of suicide or suicide ideation. Patient has 2 sons and is currently separated from his wife of 50 years. During a conversation with a CNA, patient reported an increase in depressive symptoms due to feelings of isolation and loneliness. Patient reports that his sons do not visit as frequently and reports, if I were dead, no one would really care. Patient also stated, my faith keeps me going. He reports feeling hopeful that his physical and mood symptoms will improve. Patient reports that despite his feelings of depression, he enjoys watching television and attending activities. Is this an immediate or less immediate situation? Less immediate. There was risk factors that were identified, right? He has family and he has faith. But what do we do? Should we just say, oh, well, let's hope you get better? What do we do with this situation? We monitor it, right? We want to make, while we are not going to go and remove all of his items, we do want to screen further, right? We want to do a risk assessment. So the reason I chose this scenario is because it's pretty typical of what we see. The other ones are pretty straightforward. If they're saying they're going to hurt themselves, well, that's a no-brainer. We know what to do. Make sense? Yes. Okay. All right. We're getting there. All right. Any questions so far? All right. Again, I'll introduce the word postvention. It refers to activities designed to comfort and protect people who have been emotionally affected by suicide or an attempt. That includes all of us. Yes?
I'm sorry, what did you say that was? You said we're doing what now?
Postvention, the word, yes.
Thank you.
You're welcome. Finally, how can we reduce feelings of suicide with our residents? There are 3 major ones based on research.
I think interacting with them, activities, just spend a little time with them, try to get them up out the bed, TV. A lot of them sit in their room with no TV on the whole entire day, and I'm like, put the TV on or something,
Good.
Spend a little time. I don't know
Sure.
what else really off the top of my head, but definitely some interaction with them.
Sure. And we'll call that connection. Good job. You had the first one. Strong social relationships and connections help prevent suicide. These include connections with family and friends, staff, and the community. Simple interactions, day-to-day interactions make a difference. You get to go home. They hang out back, right? They hang back. This is their home. Number 2, positive outlook and a sense of meaning in life. Oftentimes our residents, they lose hope. Well, I have nothing to live for anymore, right? Asking residents to participate in resident council activities, inviting residents to participate in volunteer activities, providing opportunities for culture and intellectual activities, including music, books, puzzles. I'm excited to get to know the activities coordinator, director, and your center. You play a big role. Are they here? Oh, hey, good, okay, good. Big difference. You play a huge role in their lives. Number 3, positive physical environment. We can provide areas for both large and small group gatherings. We can involve residents in decorating their physical environment which promotes social connection and gives them a sense of their space. This is mine. It's me. It's tiny, but it's mine. Make sense? Any questions? Again, you get to go home. Our residents stay behind. And oftentimes, the highlight of their day is seeing you guys. You guys have been great. Thank you. I'll hang back if you have any questions.